The cornea is the clear window of the eye. It allows light to be focused onto the back portion called the retina. Keratoconus is a disease that can compromise the integrity of the cornea by becoming misshapen. This is a process called ectasia. This predisposes to thinning and bulging of the cornea. So instead of having a curved football shape, it becomes more pointed like a rugby ball. This in turn increases astigmatism when light is focused in different directions on the back of the cornea and onto the retina, and indeed myopia when an image is focused in front of the retina. Figure 1, a side profile cartoon showing a normal cornea, A, and thinning and bowing associated with keratoconus, B. Both men and women may develop a condition, and this usually starts when we are teenagers or in our early 20s. The condition is problematic as it may continue to progress until vision becomes compromised. And this is usually through blurring, and this is often noticed when one can't manage with spectacles or conventional soft contact lenses. Although inflammation of the surface of the eye, such as in allergy or certain genetic conditions, can result in keratoconus, usually a direct cause cannot be identified. An optician will often become suspicious that you have keratoconus when they test your spectacle prescription. They or you may notice that you become more short-sighted or that your astigmatism has got worse. They may also notice that you have changes in your cornea that suggest you have keratoconus. Normally, they will refer you to see the ophthalmologist and eye doctor, who will also examine you and undertake special tests, such as topography, a painless test that measures how steep and how thick your cornea is and can determine the degree of astigmatism, an OCT test, which is also a painless light-based test which measures the profile of the cornea, and finally specular microscopy, which can determine how the cells lining the back of the cornea may behave should you need further treatment. Sometimes the diagnosis is not clear, and you may need to be monitored for a period of time to see whether you are developing keratoconus, so these changes can be monitored and to decide if the disease is actually progressing, getting worse, and would benefit from treatment. So how do we treat and monitor the condition? Keratoconus cannot be treated with eye drops or tablets. Often, and as long as we or your optician think it is safe, we will try and improve your vision with contact lenses if glasses are of limited help to you. Contact lenses usually need to be hard, rigid lenses, or occasionally specialist scleral lenses to fit over the misshapen cornea. Patients usually find contact lenses better than glasses as they allow light to enter the eye more normally, improving quality of the image that you see. If there is evidence that your disease is getting worse and it is safe, we will consider arranging a treatment called corneal collagen cross-linking to prevent the eye from warping further. Sometimes the cornea can become so thin that a break, which causes fluid to build up, which can be painful and suddenly causes clouding of the vision. This is called eye drops and will need attention from your doctor quickly. It involves specialist eye drops and can lead to scarring of the cornea. So collagen cross-linking is a treatment that aims to stiffen or harden the cornea and prevent it from becoming misshapen further. Although very long-term treatment data is not available, this treatment has a good safety profile and low risk of complications such as infection. It also helps in trying to prevent the disease from progressing. Further details can be discussed should you need this treatment, but briefly, it involves a day case procedure that requires the application of specialist drops followed by ultraviolet light shone on the eye for several minutes. Keratoconus can result in the cornea becoming so thin that cross-linking is not safe or likely to be effective. Too pointed or scarred, the keratoconus cannot be managed by specialist contact lenses, or you develop a perforation, or when one cannot wear a contact lens itself. In these instances, it may be necessary to replace part or all of your cornea through surgery by undertaking a corneal transplant called a graft or keratoplasty. There are 3 layers in the cornea: the epithelium, the front part, the stroma, the middle part, which makes up most of the cornea, and the endothelium, which is the back surface, acting as a pump to stop the cornea from becoming waterlogged. There are 2 broad approaches in keratoconus itself: penetrating keratoplasty, which is a full thickness corneal transplant, or an anterior lamellar keratoplasty, which is a partial thickness transplant replacing the epithelial and the front part of the stroma up to a 90% depth. all involve the replacement of some or all of your cornea. And like all organ transplant, this involves taking corneal tissue from someone who has died and donated their organs for transplantation. Further information can be found in your leaflet and video concerning corneal transplantation. We will determine whether you have keratoconus, whether it needs treatment with contact lenses, cross-linking or surgery. If you do not need treatment other than lenses, we will usually monitor the condition every few months to see if the disease is progressing, and you would benefit from treatment. Other advice for patients with keratoconus include stopping wearing your usual contact lenses prior to and after your clinic visits as advised, so we can get an accurate scan and determine progression. Contact the department as soon as you notice any problems, for example an increased blurring of the vision, redness or pain that is getting worse. See an eye doctor as soon as possible if you start noticing these symptoms or any problems that may be of concern, so that the right treatment can be started straight away. Most people do not get further progression of keratoconus after the age of 30 to 35, and once we establish there is no progression, we will determine whether it is safe to discharge you from the clinic.